okay. And I took him down to CT, and I did that, and he said, you know, Rhonda, he said, his presentation's really weird, take him to MRI. So I took him to MRI, he was still in a at that time we were doing alkalis, he was still in a TPA window, but he showed up DWI positive, flare negative, and I was in a window because his wife was in there when he had this acute sudden change in his mentation. And so we ended up giving him TPA, and he ended up doing just fine. But the DWI is the one that shows ischemia very quickly within minutes of stroke. And the reason why it shows it is because it's picking up some of that edema again. So you get swelling in the cells. When you get swelling in the cells, the water doesn't flow freely like it should in the brain. And because of that, you get this brightness on DWI. Okay? This is the imaging that was used in the wake-up trial. We're going to talk about it tomorrow when we talk about reperfusion therapies. When you talk about getting people out of the window, like out of the time window, this is what you're looking at. But you're also comparing it with a flare. So your DWI, so we're going to see flare in just a minute. So if you have DWI and no flare, give it. That was the wake-up trial in 2018. Okay. So this is how you use MRI when you have strokes of unknown onset. You don't know. Okay. Here's your PCA territory right here. You see midbrain. It's a little bit lower slide than what you saw before, but this is midbrain. This is posterior PCA territory right here. ACA, look at that. Looks almost just like our picture, doesn't it? And then you have MCA territory right here, all DWI. Now, over time, DWI gets darker, but in acute, and in hyperacute situations, it is bright white, just like that. Okay. Pretty negative CT. This patient's having a bad stroke. Okay? All right. Maybe a little bit of something there, the basal ganglia. I mean, I could talk myself into it, but you really see it on DWI down in here. A little bit of subcortical stroke here. Nothing here. This is an older person I know because, again, I can drive a truck through these things. Nothing going on here. But look, you've got scattered emboli here. That's your DWI. And so we'll correlate that with an ADC. And if the diffusion coefficient corresponds with this, it's actually stroke. Sometimes you can get things like press and things like that will show up here, but they won't correlate on ADC. So it's a matter of learning how to use your imaging. But this is exactly what they use. But you see how the CT is totally negative. This patient obviously is going to have some left-sided deficits on presentation, and the CT will be negative. If that patient's in a window, treat them. Okay. Perfusion weighted imaging. I don't think that we, do y'all use perfusion weighting at all? I don't think I've ever used a perfusion weighted image, so I'm not gonna spend a whole lot of time on it. I mean, you can do it with MRI. Again, it works the same principle as CTP in terms of taking the changes in the blood volume, the blood flow, and the mean transit time for the contrast to get there. And if it's delayed or impaired in some way, then you can go, okay, I have a blockage there, I have something going on. So it's the same principle that you use, and again, correlating that with the DWI, the actual volume here. This is the reduced blood flow here, okay? So again, this is just blood flow based, so if you correct them, then potentially you can reduce the infarct or the core infarct, okay? And we'll talk about mismatch again tomorrow a little bit more. Has anybody seen this nephrogenic systemic fibrosis from gadolinium? I haven't either. I mean, I've never seen it, but people have to sign for it when you give them contrast with an MRI. We don't need contrast for MRI, just for stroke stuff. I need a non-con MRI for stroke stuff, but sometimes you do have to do gadolinium, you know, brain tumor, stuff like that. But this is a complication of the gadolinium in some patients. That's the reason why they have them sign a consent form. When I started out in MRI, we didn't sign a consent form. And I can't remember, maybe it's Chuck Norris's wife that was responsible. I don't even know. But anyway, because I think she had a reaction like this, and I think after that people started talking about it. but this is one of the things with contrast that we have to consider. Flare is also what we use with DWI. Okay, flare is important, and it really should be used in as a part of the sequencing for MRIs. And again, it's going to aid in dating and timing because flare takes some time to develop. It takes about 6 hours to develop or so. So if MRI is used instead of CT in the emergent imaging of stroke, you're going to compare DWI with flare. Okay, that's what the wake-up trial did. You have DWI and no flare, you're going to give it. If you have DWI and you have flare and you have a lot of flaring around there, a lot of edema around there, you're not going to give it. Okay, so again, wake-up stroke patients. We'll look at that a little bit more when we get to reperfusion. Again, there's still an area of evolving research because, you know, stroke is a tissue-based sort of diagnosis that we're learning more about how to assess a little bit better. This is flare. See flares? It's a little flare through there. And in cases of stroke that's been there for several hours, it really gets into the territories. This is sort of a scattered flare image.
So if you had, like if you were DWI positive and flare positive, you would also have an entire area that was lit up that corresponded with the ACA, PCA, whatever. And then you just have, like, would you have like a hyperdensity within that lesion that was lit up, or would it be outside?
No, it would look a lot like this.
Okay.
It would just look edematous, like it was really highlighting the water in that, and so so it would look like that, but it would be in the same territory with the DWI.
Okay.
So they just compare the two photos between each other, and that's.
There's what?
Like, let's say they're deciding they're gonna give TNK or not, and later you just compare both DWI and flare. And say,
Oh, so you're looking at two separate images for the DVO, like they're
You're
not gonna be
looking
done
at one setting. These are sequences within the same
Got it.
setting.
Okay.
Okay.
Yeah, these are sequences, all that you get in one setting of an MRI. When we did our MRI stroke protocol,
You said this takes 6 hours though to develop.
what it does to show up is flare. Yeah, to flare up like that.
So if it
takes
has
some
flare,
time.
it's an older
it'll
stroke.
show up like that.
Yeah, it sort of helps you age it a little bit, because you know that DWI is positive within minutes.
Okay.
Does that make sense? And so these are all sequences that I will pull up. So these are all MRIs. You have different sequences. We'll do a T1, a T2, a DWI. That's why it takes 20 minutes, or more if you're contrasted, which we don't need for stroke. That's why it takes so many, is because they're getting all of these sequences that we need. They're spinning the hydrogen. It's basically, we're all water. So they're spinning the hydrogen and then relaxing them. And so they're doing, and then they're doing the stuff within the magnet. And then some of this is being sort of manipulated by the software as well. And so that's why it takes so long. CT is easy, you don't need to do any of this stuff. But MRI, I need to know these sequences, because depending on how I spin those atoms, and depending on the magnetic field I put to them, then it shows up differently. But this is all one setting, so it's not just one. It's not I'm doing an MRI here and I'm doing an MRI there. These are sequences all in the same MRI setting when they go in the room.
So flare's like the one where the radiologist reads 6 hours to like 2 months old? Is that the one?
It could
Like
be,
the,
yeah,
where
it
they,
could be.
how they
So when
read
I
it?
pull up a quadrant of 4, like when you pull up your packs, I pull up 4 squares on my box. And I pull up a DWI, I'll pull up an ADC, I'll pull up, ours is a SWE instead of a GRE to look for blood, and I'll pull up a flare. And so I pull up those 4 sequences when I look at MRI. Yeah, but the flare should correspond, if it's an older stroke, even if it's out of a window. But the whole premise behind the wake-up trial was that you had stroke and you didn't know how old it was, but you're using the flare to sort of age it a little bit. Yeah.
So just to clarify, so DWI and flare, if you transpose those on, would they look exactly the same? Or?
Flare is gonna look a little bit more edematous than the DWI, because it has all that edema around the water. So if it flares up, because in infarct, you get a lot of cytotoxic edema from the just cell death and then the ischemia related to that. It's gonna be in the same territory, but it may look a little bit bigger because of the edema. Yeah. Okay. So I would encourage you, when you're looking at MRIs on your stroke patients, and you just look at DWI, go ahead and pull over the ADC, because the ADC should mirror the DWI. The only difference is where the DWI is bright, the ADC will be dark. Go ahead and start pulling those up so that you can see. The advantages of MRI is that it's more sensitive to acute ischemia and certainly infarction. More sensitive to posterior fossa lesions, because remember, the CT scan has to burn through all that bone. So if I have a concern whether I have something going on the posterior fossa and the cerebellum, I'm gonna get an MRI. They're gonna get an MRI anyway. They're more sensitive to small vessel lacunar lesions. Can't see them anywhere else. And certainly those cardioembolic ones. They're more sensitive to microbleeds. You're not gonna see that on CT. It's a long scanning time. MRI is not universally available 365. I have to call people in sometimes on the weekends. They don't like it. So you try to get that staffing as best you can, but sometimes it's not just 24/7 in some places. And again, you have contraindications, pacemakers, or, cardiology has to come and clear the pacemaker, or, you have to make sure they don't have an extra lead in there, those kinds of things. You don't always get the visualization you want in those distal branches, and it's prone to artifact. So if I have coils, a patient, I get a ton of artifact. If I have dental fillings, ton of artifact. So there's a lot of artifact that you can get with MRIs. Okay, we are on the downhill slope here. Okay, catheter angiography is considered the gold standard and was for many, many years for vascular imaging. Typically, when you do four-vessel angiography, you can diagnose lesions in the neck and anterior and posterior circulation of the brain. You can look at all those. You actually use the less contrast and less radiation than CTA. The only problem is it's invasive, right? You have either a radial sort of access or a femoral access. But the sort of gift of that, of catheter angiography, is that you can go to treatment if you need to, okay? The complications are less than 1%, and the most common ones are obviously hematoma and the access injuries. But do y'all do radial access?
Yeah.
You do both of them? Yeah, okay. How do you decide whether to do radial or not? Oh, really? Okay, so it's what they've been trained in doing. Gotcha.
Is that a Corner's test?
Okay. Huh?
What is it, just Allen's test?
Yep, you can. And so typically, I don't know that it's always 100%, but typically they'll do that. I mean, we'll do that when we'll place art lines and stuff like that, yeah. But a lot of times it's where they're trained. It's hard when somebody is used to accessing femoral, because they're used to that big vessel, to go to radial, especially in women. I think that would be a hard transition if you weren't trained that way.
Do you guys see a lot of radial access in neurointervention? I feel like the patients we see in ICU are almost always groin access for thrombectomy, but I mean, that's thrombectomy.
Yeah, I think thrombectomy is gonna be different because you have to have all the devices that go up there.
Right.
For y'all are outpatient, so they're probably more elective
probably
and more diagnostic than.
I mean, I don't think we see a ton of radial access in ICU, anything that comes from
Duckworth will be
neurointervention.
your only radial access one.
We see more radial access up on neuroscience than femoral generally, unless they're doing a thrombectomy. But if it's
Yeah.
just an angio,
Yeah, but it's just an
they always
angio.
come up with the bands on and.
Yeah,
I mean, sometimes
And
they'll have
that's
to
nicer for the
go radial
patient
to
because-
femoral if they're not able to access
yeah,
it.
that's nicer for the patient. One of the things that we have difficulty is the site assessments and the distal pulses. I mean, we do them, the documentation behind them is always a challenge.
6 hours after.
Huh?
Can't stand for like 6 hours after.
I know, so the patients hate those, they really do, yeah. Okay. So DSA is what they do. And so it's additional subtraction in geography. So it subtracts out the bone, right? I don't know how many of y'all been in the interventional suite? Yeah. Yeah, I mean, it's a pretty cool place to be, but you see the carotid? See the ACA here? It's going up, and then you see the MCA here with all the little branches. Yeah. See the bifurcation here? I feel like that there needs to be more contrast through here, so I'm not exactly sure if they captured that in the as soon as the arterial phase got, as soon as they got it, but anyway, that's a nice angio. Okay, again, post-procedural management for these patients, distal pulse assessment, puncture site and bed rest, and the radial access is a lot more flexible, people like it a lot. Okay, I think last thing, Doppler. For our conference, I did the Doppler course, because Doppler was always confusing to me, because I don't do it. I mean, I can look at them and I can know if patients have vasospasm, but I just don't do Doppler. But anyway, it's named after Christian Doppler, who developed it, and that's the reason why it's always capitalized, because it's actually a nice name. But he really defined the Doppler shift, and so it's a change in frequency of sound or light, can be either one, as the source or observer moves away or from each other. So it's like, it's like the ambulance thing where the sound goes out and it just, that's Doppler shift. And so we use that principle to do things like TCD, where you're going to initiate a wave, and it's going to bounce back off of tissues, and it's converted into an electrical pulse, and then produced into waveforms, okay, as a brief, all right. You don't need to know how to read carotids, Dopplers to know that this is a problem, all right? Nice blood flow, nice blood flow. The B and the red, the blue and the reds have to do with what's moving towards you and what's moving away from you. And so the gray image is in the B mode. Color flow is the actual Doppler. And so you really do need both so that you can really assess the blood flow in this patient. And you can see that we have quite a bit of stenosis right there, okay? A little bit of pressure, a little bit of retrograde, and this looks okay, just narrow through here, okay? So that's how we use Doppler. Now I have, what is this? Let me see, do I wanna say anything about this? I'm gonna say a little bit of something about this. You don't have to memorize this, but when you're looking at your windows, some patients, especially aneurysm patients, they don't have great bony windows. But what you're hoping to do on some of these, like especially the transtemporal, is you're hoping to see movement of the MCA towards you. And depending on these waveforms, because you can get waveforms that are like this and it's moving away from you, these are towards you, and that you can assess where the vessels are. Now, I have never, quite frankly, ever understood that, to be honest. And so last year I did the vascular, I did the TCD workshop at the AMBC conference, and I did the transorbital, and I put the probe on my eye, and then trying to find the vessel, and then you do the same thing on the temporal, trying to find the vessel. Okay, so I did the transorbital. Now the next day I had my eye hurt, but but just say, and I think it was the pressure on it. I don't know. I'm probably not going to do that again. But anyway, but you can see the blood flow that's either going towards you or away from you. And then you can see, and then from that information, you can determine what vessel it is. I mean, it's pretty neat stuff. But these are typical transorbital. We typically don't use that, but that is a window that you have. Because and in some cases, in trauma, they'll put ultrasound, not even a TCD, but an ultrasound to measure the carotid, the optic nerve sheath, to look for ICP in patients. So they'll do that sometimes too. But anyway, transtemporal is a window, submandibular is a window, and the transforaminal back here is a window where you have a window into the skull itself so that you can look at the vessels. So this is what we use. Typically we use this one, but any of these can be used to assess for vasospasm in our TCDs. But it was really interesting because it's really hard to find the vessels. I mean, it really is, operator dependent, to how to use this. It was really interesting, so if you get a chance to do that, it's kind of fun. Again, why do we wanna do it? Vasospasm detection, peaks at 5 to 7 days in aneurysmal subarachnoid hemorrhage, and we do serial monitoring of that. Sickle cell disease, the primary care, prevention guidelines recommend using TCDs for, monitoring for increasing velocity. If you have increasing velocities, you're trying to push past something. And so it can indicate the need for transfusion. There are, in terms of experimental, uses, to monitor, you know, the recanalization with TNK. You ought to ask Andre about that when you see him Friday. He's done some work on using TCD to monitor recanalization. So you might ask him, say, hey, what is this all about? You might ask him because they've done some of that, which is kind of interesting. Monitoring of vasomotor reactivity, and monitoring of brain death. Typically we have other ways to do it, but you can use it if you don't have any other thing to use.